25 plus years, supporting best practices, working with mothers, babies, and professionals. She has a busy independent practice where it's an honor to work with new again, or soon-to-be parents. Sonya has a broad range of experiences supporting healthcare professionals to provide infant feeding evidence-based care. She has been instrumental in developing resources regionally and provincially as a provincial health promotion consultant with the BFI strategy for Ontario. Sonya assisted healthcare organizations like hospitals to progress in implementing the WHO's Baby Friendly initiative. She was the coordinator of the provincial breastfeeding protocols, including informed decision-making, infant feeding, and has facilitated informed decision-making workshops across the province. Some nuggets of this presentation are from her provincial work. As an IBCLC and registered nurse in various roles such as public health, northern nursing in Yukon, Canada, and as a birth doula, and as an independent lactation consultant. She's been fortunate to work with parents in the whole continuum of childbirth. So welcome, Sonya.
Well, thank you very much. I just want to confirm again that you can all hear me all right. Yeah, lovely. Thank you for the introduction and for the invitation. The topic today is informed decision-making, gaining skills with tricky breastfeeding-related conversations. Hopefully by the end of this, you'll be able to understand various scenarios where you'll be needing these conversations if you don't already. Learn at least one, two, maybe three relatable conversation starters to an IDM or informed decision-making conversation, and summarize some components. Also, some resources will be available for you. When we think of times that informed decision-making conversations, and I'm using IDM for informed decision-making, when it's needed at multiple points of time. It's needed for pregnant parents. Really, it's made to be good for preconception. It's needed in labor sometimes. It's needed for people who want formula on the second night. People who intend to mix feed or who need to short term. And it's for parents then who are pre-pregnant, pregnant, and after delivery. So many different points in the journey. And what's interesting about this is it's about the decisions actually made many times, and it can be about what to feed, and it can be about how to feed. So what goes through your mind when you're needing to have an informed decision-making conversation? What are some of your concerns? I just had one this morning, and it's like, I don't really want to do this, but I need to do this. And how can I do it in a compassionate and informative way so this mom can make an informed decision? Just think about some of those concerns that you might have when you're having these conversations. These conversations are really important for parents. They're really important for healthcare professionals too. Parents want to trust and get informed by their healthcare professional. It helps with downstream trust and downstream efficiencies. And it certainly helps way down the line when someone says, why didn't they tell me? It is part of patient-centered care. It's an ethical issue. It's that important, and it's a human rights issue. And it helps with adherence. When people are making a decision based on information, they're more likely to stick with it. Yet we know that physicians and healthcare professionals, their application and adoption of informed decision-making, or SDM, which is shared decision-making, which I consider an acronym, is low. And so they're not confident. And so perhaps some of us on the call are not confident with informed decision-making conversation. And there's a lot of literature that brings that up. It is, however, super important for parents. And so you end up knowing that you're successful when the parent is part of the process. It's not like you've gushed out a bunch of information and you go, I'm done. However, we still want the parent to be knowledgeable about infant feeding. And if they don't know, they can't make an informed decision. You're successful when the parent is comfortable with the decision. that it hopefully acts within their values and personal preferences. But say there's a medical need, that the parents will completely understand that, so they can reconcile the need to act outside of their beliefs and values, at least on a short-term basis. Informed decision-making is not happening if parents don't know the benefits and risks of the options that they are considering. And this is where these conversations can get really sticky, because the tendency is to want to support parents exactly where they are at, and that is important. And they need to know the risks and benefits of what they're choosing. It's not happening if there's a perceived lack of options, if there's only unacceptable alternatives. If it's not based in research, we're not doing an informed decision. We're not helping them make an informed decision. If they're saying, please give me some formula, and you go, yeah, sure, it's all the same, that is not evidence-based. It's not happening if healthcare professionals do not know the parents' beliefs, values, or goals, or if it's one-sided. In a very narrow little window of trying to learn something from your client, you might say, how do you plan to feed, or do you plan to breastfeed? You get a yes, no, which is already really minimal information. And the client is gaining no clarity. That is not an IDM conversation. And it's not IDM if you're deliberately biasing the opinion of the client. That undermines the process. I think you should give some formula. Really, we're speaking from a position of power, and that can undermine the process. We need to very much consider client perspectives, so their past, present, and future. So what issues did they have in the past? What biases might they have? What did their sister and their grandmother and their mother do? Where are they coming from medically? Maybe their own breastfeeding history, and psychosocially, where are they coming from? In the present, we need to look at the whole context and remember, yeah, just the big picture of what's going on with these people. And the big picture is not a 1 hour in-depth study, because that's not realistic, but we do need to consider their bigger picture. And when we're helping them think about their options, we might suggest they look back, pretend the decisions happen and look back, ask them how they'll think about this decision once they look back on it. Sometimes that makes the client one step removed and look back, and it helps them to get a little bit more clarity. So remember that the healthcare professional comes in as an expert in clinical evidence, and the client comes in as the expert with their lived experience. Discussions are not cookie cutter. I can't tell you you're going to do A, B, C, D, and you're going to repeat that with the next client, the next day, the next day. They're all going to vary. The student that I'm working with, I say you have to dance in the conversation. You have to dance around and with their personal circumstances, the patient's condition, the degree of urgency. How complex is the situation? The degree of potential harm. Are you going to send somebody home who needs to formula feed and they don't have clean water? There's all kinds of things to consider. That and the client or the patient's temperament, their attitude and level of understanding. And what information do they need to know? As we all know, some people need to know lots of information, lots of details. Some are good at figuring it out themselves. And there's lots of people that are somewhere in between. And then, of course, there can be differences and challenges with language or culture or ethnic background. So we need to work with those things. To make this as practical as possible in the time that we have, I wanted to bring up a few situations. So for example, you're working with a couple in late pregnancy. This picture comes from some videos that we did with the BFI strategy for Ontario. A colleague of Louise and I was in charge of this, and these, we're going to give you a resource sheet, and these videos will be on that. So when you're with these people meaning people in late pregnancy, you want to explore the situation. You want to build on their existing knowledge, And you've got the luxury of time and non-pressured situations. So it's lovely if you can do it anywhere in pregnancy or even start pre-pregnant. You want to approach the conversation in a non-judgmental way. Confirm their understanding, and then you can sort out, what's true, what's not, and help them with making more of an informed decision. Then determine their additional needs and their next steps. This is probably not the crowd where I need to explain the risks of not breastfeeding. I still find people are all over the map on how they use language in terms of this. Do we talk about the benefits of breastfeeding, the risks of not breastfeeding? Sometimes people aren't comfortable talking about the risks of not breastfeeding, even though there's a big argument for doing that, in that we're talking about the biological norm is breastfeeding. So if you're not breastfeeding, here are the risks. So some people might use the language of the importance of breastfeeding. And this is not totally comprehensive, but it's good for us to have some of these things at the tip of our fingers, tip of our tongue, so we can just tell parents. And sometimes it's good for moms all the time to know that there's risks of not breastfeeding for them too. So sometimes that's the motivator. Sometimes parents are tapped out of doing what they need to do or want to do for their baby. And sometimes it's okay to motivate them to go a little longer if that's what they want and try XYZ, because they are the motivator. They are going to benefit from breastfeeding longer. So again, it's good to have some of these health reasons at your fingertips. And then this is becoming a bit of a topic for me. I might expand on this at one point. How a baby feeds breast milk really matters. We're seeing a lot of momentum, I think, to, well, it doesn't matter as long as they're getting breast milk. But we're not being evidence-based when we do that. It's true when it comes to data collection, we might be doing that. But when we're talking about a culture where we're sort of like, well, we can just exclusively breastfeed, bottle feed breast milk, there are differences. And when we're having informed decision-making conversations, we need to also know some of these things. So if a baby's not directly breastfeeding, and I don't mean the occasional bottle, I mean predominantly, we're talking about differences in acute and chronic illness prevention, in the immune response. There's higher rates of asthma, type 2 diabetes. Again, this list is not all inclusive. Babies are less likely to get milk for as long as if they're directly breastfeeding, and milk mom's production isn't as likely to last that as many months. The microbiome is altered without the direct skin to skin. The appetite regulation is different. Normal weight gain doesn't necessarily happen when they're predominantly fed by bottle. They don't get the benefits of less pain when breastfeeding, and there's differences in oral motor development. This too, we want to be able to say to our moms who are thinking, you know what, it hurts when I breastfeed. I think I'm just going to go to the bottle. And sometimes these are great conversations to know some of these things, to be able to say, I'll support you whatever you decide, and I want you to know that it's different. And, would you like to stick with your original goals? And I can support you with that. In another situation, a baby might be newly delivered, baby's crying, parents are exhausted, they're asking for formula. It happens all the time. If you work in a hospital, it probably happens a lot of shifts. Tip number 1, explore the current situation. You've heard that before. We want to provide positive feedback. Every parent has their doubts, especially the new moms. Am I holding the baby right? Am I burping the baby right? Is this going okay? How's my baby? So there's always things to give positive feedback on, encourage the client, the patient. Discuss her original feeding plan. Do you want to be supported for your original goals? If yes, then how can we help you get there? We can explain how formula might affect her goals and normal behavior, and that there's some risks involved with it. We can teach about normal newborn stomach capacity, and that colostrum is meant to be enough. We can talk about ways to know baby's getting enough, review signs of that breast milk transfer. Also teach that babies can be fussy. It doesn't always mean they're hungry. Obviously, we want to help them with breastfeeding if at all possible. And I know people have different levels of skills related to that. And for parents to understand that there's different ways to help a fussy baby, in terms of maybe rocking, finger sucking, skin to skin, different ways to hold the baby. In the end, of course, we're going to support her in whatever she decides, or maybe she decides something for short term and then we want to salvage it, not salvage, but keep the breastfeeding relationship as much as possible, or keep the milk supply as much as possible if she needs to have a short-term break, or she needs to do something for a short while and think about her options for later. If needed, we're going to have to teach some moms and dads how to safe formula feed to keep baby healthy, and know that she knows the resources for follow-up, the resources in the community, the resources beyond you. Here's another situation. The client is formula feeding. It's shortly after delivery, and she did not make an informed decision to formula feed. What do you do? It's very easy to say, well, she started formula, we're just going to go with that. It's important to understand some of the research. This study from 2016 talks about reasons parents chose formula. They chose formula for maternal reasons, like it avoided pain. They didn't want to be tied down. It's more convenient. They didn't want dad to be left out. And all of us who've been in practice any amount of time, we know that, there's a lot of, I want dad or my partner to feed the baby too. Misinformation is sometimes behind the decision. So it's all the same. Milk is milk. I don't want my breast to be saggy. Breastfeeding babies cry all the time and they're up at night a lot. And the pediatrician said it was up to her. Notice that none of these mothers spoke about the health risks associated with not breastfeeding. So did they really make an informed decision? So you can ask, what made you decide to formula feed? What were you thinking when you made this decision? And understanding again in the back of your mind that reasons parents choose breastfeeding is often because they have sought information from family, friends, health professionals, literature, all the places, internet. They've taken classes, they've done all kinds of things. And so what we're seeing then is that, at least according to this study, a lot of parents who are choosing formula feeding are not choosing it based on evidence-based information. So there's a little window there where we can approach that conversation and just say, hey, did you know? Would you like to have a conversation about this? But obviously that's a little bit of a tricky place to start. So here's some suggestions about how you might start that conversation. You might say, I see you started formula feeding. How's that going for you? That is not a judgmental opening. Or has anyone chatted with you about different types and methods of feeding? Is it okay if we take a few minutes to do that? So now you've kind of set the agenda and you've got agreement, so it becomes both your agenda. It is okay if we talk about that. If you get a no, then the conversation's pretty much done. If you get a yes, and most moms would probably say yes, you've got a window open. You might say, it's my job to ensure you have all the information you need. Decide what's best for you, your baby, and your situation. Can we take a few minutes to talk about it? There you've set the tone, the topic, and the agenda, and you're going to get a yes or no. If it's a yes, you've got a shared agenda. And then what were your original feeding goals? That's a line I use a lot. And then would you like me to support these goals? Because people do refine their goals. They're entitled to refine them, but a lot of times they don't even quite want to. So here's another situation. Parents offer, after an informed decision-making conversation, they either want to formula feed or they need to for medical reasons. Now, I've lumped these together, and I understand there's two very different conversations. And yet the approach is going to be similar. You're still going to explore the situation, know what their goals and values are. Some people are going to say, I just want to give formula. Some are going to say, well, if I have to give formula anyway, I may as well go all formula. So we need to explore this. What are the goals and the values and the preferences of your client? What are the cultural preferences? And if formula is considered, we need to know that it's affordable and safe and feasible for them and so on. And I don't describe it later. Sorry, I should have taken that out of this slide. We want to discuss the risks and the importance and confirm their understanding and determine additional needs. They're all going to have additional needs. Feeding your baby is, to me, one of the first great hurdles after birth. For people to get into a nice rhythm, figure this out. And for the clients that I work with, it takes a long time often. So we always want that follow-up step. It's part of discharge planning if you're a hospital-based person. So we want to make a plan, help them to know what next steps are, where they can get help, and of course, use all those great communication skills that you learned in your training. I'm talking to people with the BFIO, and yet sometimes there's a misunderstanding about it being the breastfeeding initiative. And again, you know this, it is not just about breastfeeding. It is to promote, protect, and support breastfeeding, but it is also for all families. So we want to be protecting families from marketing pressures and from all healthcare professionals from conflict of interest. And we want to support parents however they're feeding so they can reduce harm and go on to have a great time feeding their baby. So if supplement is medically needed, we want to also then talk about what supplement. Are we talking about express breast milk? Are we talking about formula? How are we going to do this? Cup, spoon, and maybe syringe or supplementer are much preferred in those early days over a bottle. We want to talk about the approximate volume needed. Decanting is amazing. There's one hospital locally where they're decanting because of the formula shortage, and I hope they continue to do that. We want to be teaching them elements of responsive feeding, particularly if the baby's bottle feeding. And again, if formula is needed, we'd want to not give a brand at the bedside or be recommending particular brands in the community. In the hospital, we want to decant what's needed and then teach them how to safely prepare, feed, and store. It's a lot of work to teach all that. I don't deny it. Parents who are mixed feelings need mixed feedings. Doing mixed feedings need a lot of teaching. And if the mother wants to return to full breastfeeding, a plan needs to be created for that. I'm a little biased about this resource, maybe, but because I was the lead on it with the BFI strategy for Ontario, it's still available at the Best Start Resource Center. It is baby friendly, and it does talk about all the things parents need to know. A bit of informed decision-making section, different types of formula, preparation, storage, how to feed on the go, how to bottle feed, and how to reduce risks. So don't hesitate to use that or something like that that is baby friendly when you're doing your formula teaching. So we want to ensure the mother understands the medical indication. I've certainly worked with people that are going, yeah, they said formula, and I'm going, that's okay. So, and do you understand why? And so they're like, no. So, I mean, sometimes they do, but sometimes they don't. So we want to be sure they do understand this is what's happening. We want to be really sensitive during these conversations using non-judgmental language and always try to build the mother's confidence. I'd suggest starting with alternative feeding methods. First of all, of course, breast milk. If you can get any breast milk or mom can get any through expression of any type. And then in terms of how to feed, again, if we're talking small amounts, we don't need bottles for that. And teach the safe feeding preparation storage if they need that at discharge or if they need that in the community, because by the time they get to the community, they might not know that. So if you're community-based, that may end up becoming your job. Some key messages: engage the mother. It's a discussion. It's a two-way street. In some ways, the term shared decision-making is almost a better term than informed decision-making. And you can use what you want, but understanding that it's a two-way dialogue. Use a lot of open-ended questions and listen. Listen when they're silent too. Mom I just had recently was very quiet and I had to keep saying, what do you think? You know, because we can say things and think they're just going to go do it. And it's like, how do you feel about that? And then then we get more of that two-way dialogue. Understand that parents can take in more information when they're pregnant. It'd be so nice if they were all fully informed before delivery. I know that's not our today's reality, but use the opportunities that you have. Don't assume that it's been done. And we have no way that we're tracking through the system that informed decision-making has been done. And like I said at the beginning, it's often happening many different times throughout their feeding journey. By the time they're postpartum, they're often overwhelmed. They can maybe take in little pieces. You can maybe negotiate for, how about you do this for 24 hours or for 48 hours, and then we'll reconnect. Consider her original feeding goals. Allow time for them to think, ask questions, of course, be non-judgmental and respect her decision, especially once she's made an informed decision. And you can tell her, I use this all the time. I say, I'm going to support whatever you decide. Let's talk about the options. And it's good to self-reflect and say, hey, what did I do in this conversation that went well? What could I have done differently? How did the mother perceive it? And use that opportunity to just think about it for the next time, which again will not be a cookie cutter. So every time it's another self-reflection. Again, the conversation opener could be something like, it's my job to ensure you have all the information you need to make an informed decision. Has anyone chatted with you about different types of and methods of feeding? Would it be okay to talk about options? Then conversation closers can be, did you share what's important for you? How do you feel about the options? Do you understand the risks and benefits? And do you know support's available to you? It might be that you are not going to have another conversation with this particular person, so you need to know that they're going to somebody else where they will get support. So wrapping it up, you want to explore their beliefs and practices, explore their original feeding goals in the current context, support them in a non-judgmental, unbiased manner. Know it's your job to provide evidence-based information. It's not, we sometimes feel guilty, I think, to provide this information, but it is your job, and we want to do it sensitively. And we're not then responsible for their feelings if we've been sensitive and honest and truthful and evidence-based. We always want to include the importance of breastfeeding, the risks of not breastfeeding. Support the parents who are considering formula or who are using it. Document your discussion. And again, ensure that parents know next steps. Where are they going to go next? For the tricky conversations, these are tricky. They're life-changing too. So we want to be compassionate. We want to be truthful. We want to be evidence-based. We want to be supportive. And know that it's a fine art that all of us are continuing to develop and tweak. Certainly I am. And you'll get better with practice. And that's my presentation. Thank you.
Thank you, Sonya. That was amazing presentation with so many key thoughts that I think anybody working in with families, this should be a required presentation for them because there's so much good information in it. And you know, your comment about the dance of the conversations is so true. So thank